The next topic, the Dr. Kantapon Disanivet from Prince of Songkhla University. He will talk about the polytrauma in geriatric population, analyzing outcomes from surgically managed multiple fractures.
Good morning, ladies and gentlemen. I am Kantapon Disanivet from Prince of Songkhla University. So today, this topic is really hard and it's quite new for me too. So polytrauma in the geriatric population and analyzing outcome of surgically managed multiple fractures. So we have two words. We have polytrauma and polyfractures. So let's take a look at what it is. So today I would like to talk about polytrauma and polyfractures, an issue in geriatric polytrauma, and then also outcome in geriatric polytrauma with multiple surgically treated fractures. So first, polytrauma versus polyfractures versus polytrauma. So usually when we talk about polyfractures, we think about low ISS score and normal GCS, no head, chest, or abdominal injury. So think about distal radius fractures with femur fractures, or hip fracture with proximal humerus fractures. These are what we would call polyfractures. So multiple fracture essentially. But polytrauma, these are associated usually with high ISS. Normally we talk about ISS of more than 16 or 18, low Glasgow coma score, and associated head, chest, and abdominal injuries. So I would say polyfracture is bad, usually for us, but the polytrauma is worse for the patient. So maybe they have just one fracture. It's not too bad for the orthopedist, but it's bad for the patient, right? So what's the worst? So these are polytrauma with polyfractures. And today we will talk a little bit about this, as there are not many literature regarding this at all. So introducing the issue in geriatric polytrauma. So there are three main things that we have to be concerned when treating geriatric polytrauma patient. So first is the physiological changes. Second are their comorbidities. And the third is mechanism of injuries. So defining geriatric. So according to many guidelines, there are still no consensus on what or who we should call geriatric patient. Some surgeons now, they are nearing their 60 or 65. Some are 70 already. And I assure you, those surgeons do not think of themselves as geriatric patients, right? So the range varies. Sometimes 55-year-old patients are considered geriatric patients. Sometimes 80 years old and they still can kick the bucket. So they say, I'm not geriatric yet. But the most common cut-off point for geriatric patients are 65 years old. So these are most commonly associated with the EAST guideline from Europe. And the first issue, the physiological changes. So these are really important in understanding why they do worse in geriatric polytrauma. So first, even without any comorbidities, the body that they have been using for 65 years, so it's like the car, right? You use it for 10 years, it's not as good as new anymore. So the overall decline in bodily function occur regardless of if they have comorbidity or not. The stroke volume, the renal reserve, the shock response, the catecholamine released after injury, and the lung reserve. All of these decrease according to your age. So these all lead to lower physical reserve, and so higher rate of mortality regardless of comorbidities. Secondly is the osteopenia and osteoporosis. So older people have a lot more incident of osteopenia and osteoporosis. So this lead to more life-changing injuries such as the hip and spine fracture, as we already aware of. These fracture, hip and spine fractures alone, they lead to about 20% of 1 year mortality when they occur alone. So if we think about both occurring at the same time with polyfracture and polytrauma, the mortality rate go up. as well as the osteoporosis as a risk factor for non-union. So this leads to poorer functional return. Thirdly, and maybe one of the most important one, is the change in immune response. From study, we know that patients with critically ill from injury can have their neutrophil function decrease for up to 5 weeks. So this leads to more infection and wound complication after surgery. Next up are the comorbidities. So 50% of patients in this group have at least 2 comorbidities, and at least 25% have at least 3 comorbidities. So the most common comorbidities are the hypertension. So these by themselves are not to be scared of, but when in conjunction with the polytrauma, this can mask the hypovolemic state. So sometimes they are in shock, but just BP 100 over 60, and we still think it's still okay. Patient with the coronary artery disease and congestive heart failure, this can lead to arrhythmia and poorer cardiac output, which leads significantly to poorer functional outcome and mortality rate. Renal insufficiency contribute to electrolyte imbalance and fluid overload. Sometimes we give too much IV and then they end up with pulmonary edema. Pulmonary disease, this increases the chance of ARDS and also worse response to hypoxia. So as I said, the reserve is not as good as normal. And with the lower reserve from their decreased body function, combined with pulmonary disease, the functional reserve of the lung goes down significantly. And the lung complications are the leading cause of death in polytrauma patients. And lastly, diabetes mellitus. This contribute to overall increase in infection and cardiac and renal complication. And lastly, the mechanism of injury. So up to 70% of these injuries are low energy fall. So it looks benign, right? How could low energy fall lead to polytrauma with polyfractures? So as maybe sometimes we may not think, but some of us may think that, okay, these low energy fall are not to be scared of, but actually we are underestimating these kind of injuries. And sometimes we even miss some injuries from these falls. And also the high energy trauma in geriatric patient is not the same as in the younger patient. So actually the high energy trauma, the speed of the high energy trauma is lower and lower incidence, but this lead to higher mortality compared to the younger patient group. So with all of these, so I would like to talk about consideration in geriatric polytrauma. So what should we do? So first, these are according to the EAST guideline, which is one of the most comprehensive guidelines in treating geriatric polytrauma patients. So first is the more aggressive resuscitation. So sometimes you see patients still not in the typical shock yet. So maybe they have a pulse rate of 105, BP is 100 over 60. So these are still maybe grade 2, but in reality, they may be grade 3 or grade 4 already because of the body response is not as good as when they were young. So we should consider the lower threshold for trauma activation. So the trauma activation protocol where the trauma surgeon is more involved in the treating of fracture care, and also lower threshold for ICU admission and monitoring. Some guidelines even go so far as to say that the pulse rate of more than 110 is the only indication for the trauma activation in some patient, in the geriatric patient. Also, this leads to the involvement of multidisciplinary team. So I believe that all of us are not expert intensivists, so we do not know how to give a balance between IV fluid compared to the intensivist or the ICU guys, right? So the trauma surgeon is our friends. Sometimes with the FFP alone, with the high pulse rate of 110, we can ask them, like, can you help evaluate this patient? They may have something that we may miss. So let's take a look at this case. An 86-year-old female fall from ground level, left hip, left shoulder, and right knee pain. no other associated injury, initial blood pressure 66/44, and pulse of 100 per min. The BP is really bad, but the pulse stay quite low. So she had history of L2 to L5 collapse with the hypertension, TIA, and heart block on pacemaker. So this is the reason for the pulse rate. We do activate trauma activation, give 100 millimeter of saline and packed red cell. The BP go back, lactate of 4. CT chest and whole abdomen, no abdominal and chest injury. So this patient, they may be low INS, so just polytrauma patient. But actually, you can consider this polyfracture patient, but you can actually consider them polytrauma and treat them accordingly with activate trauma team and ICU admission. So these are the fractures. I'll just skip this. Another consideration is that they cannot withstand prolonged surgery. Maybe in young patient, you can do all these fractures in one setting, right? But in this patient, we do state procedure. Day 3, the nail for the hip. Day 5, the nail for the plate for the femur. And even the third state, they cannot withstand it anymore and opt out of surgery. So even polyfracture can be unstable. An outcome of polyfractures. So in hospital mortality for polyfractures without polytrauma is about 5% in patient with multiple fractures compared to patient with isolated fractures. So about 2 times. So 2 fractures, 2 times the mortality rate. And for the outcome of polytrauma with fractures, in high energy trauma, severe head is excluded and 1-year mortality is 34%, with 40% die within the hospital. Risk for poor outcome is femur fractures, pelvic fractures, and scapular fractures. Comparing high versus low energy trauma, we see that in hospital mortality is higher in high energy trauma. But comparing 1 and 5-year mortality, about 50% of patients with low energy trauma die after 5 years. So outcome of polytrauma and polyfracture is the mortality rate is about 50% in high energy trauma with polyfractures, but lower in the low energy trauma. Also, the same finding, femoral fracture and pelvic fracture is associated with higher mortality. So the key takeaway is that generally poor outcome in compared to young population, but we have to be more proactive in the management of geriatric patient because of the higher mortality rate for the polytrauma patient in geriatric. Thank you.